So let's continue from the previous. So we'll get started with a ventricular assist device, or we call VAD, or you can hear LVAD. L stands for left ventricle. Okay, so this is about, we don't have artificial heart yet. So when the patient has a problem and the patient has to, wait for heart replacement, or before that, we have to keep the patient survive, especially the function of the left ventricle. So this is a device for not permanent use, but for waiting patients until the new donor came. All right, so this is distinct from artificial hearts, which is designed to assume cardiac function and generally require removal of the patient heart. So no, we are not removing the original patient heart, but keeping that, the left ventricle is malfunctional, and we want to help that pumping function of the left ventricle. And how can we do that? So it will be obvious if you look at the shape of this. So look at here. So there is a left ventricle, and because the left ventricle may not pump it very well, so instead we bring a pump, external pump, and then bring that left ventricle blood back, and then into this pump. And then pump, of course, will pumping the blood with a pressure gradient to send it to aorta. So basically, it replaces the function of left ventricle. But the pump requires a motor, and so it requires electricity from the outside. So you see this through the patient's skin. Electricity is provided by the wearing a battery. So here you can actually think of what might go wrong with this, okay? So the complications, so whenever something else is coming to your body immune system will react to that. So in general, like try to reject the foreign material in the body. So for that, the patient may have to take immunosuppression drug. So that's complications and side effect. Immunosuppression, makes the patient more vulnerable to external infections. Okay, so that infection would be a complication. And also, whenever some of material which is not self is getting in touch with the inside the body, especially with the blood, there's a higher chance of blood clotting issue. And everyone knows when there comes a blood clotting, that can form a clot and that can shed into our circulation, that could lead to resultant stroke, so higher risk of stroke. And of course, when the patient, whenever there's a coagulation issue. So for example, we have like patients are taking aspirin, so it may not clot very well, then there's a risk of bleeding secondary to coagulopathy. So these are very important before and for performing this surgery. So this device is generally resulting blood flowing on a non-biological surface, meaning that, this is a machine, so it's not endothelial cell covered one, okay? So it predisposes the blood to clotting. There's a need, because of that, we have to reduce the clotting tendency, so the patient has to take anticoagulation treatment as well. So this is an example of one device for this. It's designed with a biological surface derived from fibrin, and does not require long-term anticoagulation. So, engineers make more innovation to coat inside the surface with a fibrin, which we will discuss later. And unfortunately, this biological surface may also predispose the patient to infection. So this is an issue through selective reduction of certain types of leukocyte. So leukocyte is white blood cell, and some problem for this is a problem in the certain white blood cells number can be different or lowered, and it leads to more prone to infection issue. So of course you can see the cut to the body surface, and all of these are like infection risk. So let's discuss a little bit of the historical use of biomaterials. And biomaterial, the simplest one can be a wound. We have to repair the wound. So surgical suture, this is thread to close up the wounds. Okay, that's like the first very old biomaterial, we can say. And there are material simply called plexiglass, like polymethyl methacrylate, or simply people say PMMA. Many times we use PMMA, which is acrylic, basically acrylic glass or plexiglass. And this have been used for denture basis, kli in Korean, artificial teeth, and surgical splinting, gumo, okay, and hip prosthesis in 1947. So like about 70 years ago, this was used like this. And also a very important biomaterial we have to know is a catheter, okay? That's basically thin hollow tubes of formed polymer. So catheter as a spelling as this, and so there is a history for this catheter, okay? So Fritz Bleichschroeder had first performed catheterization. So catheterization is a very important medical practice now, but this has like about 100 years of history now, and put it through his own femoral artery. And femoral artery is here. I put it there in a big, your thigh leg, and there is a femoral artery, which is pretty big. Okay, and then the other story is about like cardiac cath. So this is the most important in modern medicine, I guess. Say, Werner Forsman is the first one to demonstrate first cardiac catheterization in 1929. It happens to be the world economic crisis happened here, so there's a very interesting story. I brought this one in the lower. You look at the title. It's a German problem with the Nobel Prize. Like why they say a problem? Because many medical advances or innovation happened with at the time crazy guy. Okay, so Volksmann was that crazy guy that he was thinking about this catheterization may be possible to put into one's human heart. Of course, at the time, it was a crazy idea. Nobody would buy it. So he proposed that what if it would be working, this tube, which is catheter, can put it into artery, and then if you proceed, it may get inside the heart so that you can do something about this. And his chairman, department chair, was rejected that idea. Of course, that at the time, people consider once it gets into the heart, we will die. So that's a common sense at the time. But he was like crazy enough to persuade his nurse that, and the nurse agreed only if he will do it into the nurse's body. So he brought the nurse and then make a small cut into after this anesthetized, and then into the vein of her arm. But in fact, he actually just made a cut to his nurse, but not into the nurse's, but his own arm. He actually insert the catheter, and then he wakes the nurse up, and the nurse found out it was going wrong, but he already inserted his catheter into his arm. So he asked his nurse, let's go to the X-ray room. And then he went to the X-ray room, and they inject X-ray contrast agent, but he actually inserted it into 60 centimeter. And so 60 centimeter is about anatomical. It actually went into his right atrium. And that they found in X-ray image, they actually demonstrate, oh, person doesn't die even if the catheter gets inside the heart, in this case, right atrium, okay? So they actually used a urethral catheter, which is for urology, okay, via arm vein into his heart with X-ray imaging. And that time was 1929. And afterwards, because of this discovery, now it becomes a routine procedure because this is so critical for resolving this heart issue. But afterwards, he actually failed his doctoral PhD exam. So he had a very difficulty for his scientific career. And after getting Nobel Prize, he's in neurology department. And of course, he became very famous later on. So, I think this is interesting things. They didn't even perform animal experiments. They did it just human body first, and then animal experiment came later. So sometimes crazy guy or like innovation happens in this a little bit of dangerous looking, but they consider their own idea and pursue it. Theoretically, it may work to try it out. And boom, so that makes a huge difference. Let's see why this is important. Because now a modern hospital, especially cardiology department, you will see so-called cardiac cath lab. Okay, cath lab is a very popular one. So we call this is catheterization laboratory or cath lab. Okay, that's the simple people say is an examination room in a hospital or clinic with diagnostic imaging equipment. Because this is inside the body, no way to be able to see. What you need is a real-time visualization of inside the body by using X-ray. But the X-ray has to shine the heart through different angles. But our body is transparent, almost transparent to X-ray except the bones. Okay, so you do need a contrast agent for X-ray through this catheter by injection. So let me show modern cardiac cath lab look like. So this, you can see there is a plate, a bed for patient, and you see this a circular, like rotating one, because you get the angle and then make a shine to take a image of this the blood vessel first, because you are suspecting if there's a narrowing down of blood vessel, especially this coronary arteries. So you can look at this X-ray monitor to identify. Also, when you insert your the catheter has a metal tip, so that you know where it is going, so you can maneuver that. Okay, so this is a really interesting one. And also on the monitor space on the right top part is actually intraluminal visualization. I think this is the vascular ultrasound imaging. So these equipment are actually showing what's happening in the body and how will you insert the catheter. There are two ways. One is the radial artery, which is through the arm, or I think more often it goes into this groin. So guiding catheter sheath into the groin, and then it goes through the aorta, and eventually it maneuvers into finding the usually descending coronary arteries. So in fact, I had a cardiology friend, and I visited him, and it happens that there was an emergency. So the patient had a blood clot blocking her, one of the cardiac coronary vessels. So that was an emergency. So you have to wear, I think, you have to wear a apron, which is a lead, very heavy, but you have to protect because you see there are X-ray imagings like around. So you have to protect yourself. And then you maneuver with the catheter, first identify where the blood vessels are blocked by sending a contrast agent taking X-ray image, you see the blood vessels are blocked. So you send the catheter there and then grab the blood clot and then suck it out. And so you found it and the patient survived. So you see, this is like what can happen. It happens quite often in this hospital. Okay, that's a life-saving effect. Okay, so now I want to discuss with you about the biological response to biomaterial. So especially we will discuss first time with the coagulation cascade and coagulation response to biomaterials in contact with blood. So first, biomaterials in current use is we are using a lot of times a polymeric biomaterial such as catheter, okay, and coating for pacemaker lead. Do you remember the pacemaker lead has a kind of plastic coating on the outer side, so that's a polymer. And contact lens is probably the most many people are using as a biomaterial. And we have to remember no biomaterial is perfect. So that's why you should not wear contact lens to get into sleep for a long time. That's bad for your cornea, okay? So, but you can consider a common mode of biomaterial which fails. And there are two modes of this biomaterial. One is direct contact with the blood, such as so-called LVAD device we just discussed, and the other is materials with non-blood contact. So why there are problems of failure? So let me see. Yoongu? Songyungu? Yeah, can you guess what this material that contact blood have a problem, common problem is formation of blood?
Clot.
Yeah.
Clot.
Okay, yes, great. And the second, and when the material is non-blood contact, then there is a very famous response. The body tries to isolate the device from the rest of the body. Yoongu, can you guess what this is?
Feasibility.
Good guess. Let me see another. You mean?
That
Yeah.
origin.
Guess what this is?
Origin.
Oh yes, right, exactly. Yeah, foreign body response is the most important term you have to understand and remember through this class. Okay, so here comes the image of, my both parents had undergone cataract surgery. And cataract surgery is the most common surgery in South Korea. How do we do it? We suck the opaque lens inside the eye, and then you put this polymeric lens into the eye. So that's really helpful for many people. The interesting part is our eyeball is one of the immune privileged sites, so that it's, it can hold this biomaterial for a long time without much inflammatory responses. And the right-hand side is the catheter. Okay. So as a good example of biological response to biomaterials, I want to discuss about vascular graft, because many problems happen with the vessels. So for example, polyethylene terephthalate, which is a commercial name is Dacron, and polytetrafluoroethylene is a PTFE, or more commonly known as Teflon tape. Okay, Teflon is widely used for its vascular graft. So vascular graft is, graft is of course external one, which replaces our own vessels, and currently only large vessels bigger than 5 millimeter diameter can be replaced with this synthetic graft. Why not small vessels? Because smaller grafts lead to clotting and vessel failure. So that's like big issue, and still I think it's not very resolvable issue yet. That's our understanding of biology and technological limit. Okay, so graft is one thing. There's a blood vessel which is a blockage. To reconnect the blood vessel, there's another way. Instead of throwing out this narrowing blood vessel, why don't we make a bypass? Okay, so that's another approach. So that's a vascular bypass when there's a ischemia by atherosclerosis or coronary artery bypass surgery or graft. We call CABG or cabbage surgery, okay, which requires open heart surgery, or peripheral vascular disease. So sometimes we use a vascular bypass. So there's a lot of need for artificial blood vessel, and for that, how can we do this? So this is an example for vascular graft. The problem of making this from another body into mine is a problem because of immune rejection. Okay, so one idea is the proteins making for the scaffold. That's better than using a cell of another person which is not compatible with mine. So instead of cell, we use the other person's cell to produce extracellular matrix, which will form a blood vessel. And then we use that one into our own. So that's, you see, here's an example. So offline, we isolate the cells and then expand and we grow into this scaffold. Then the cells will secrete and form extracellular matrix. Okay, so usually the immune rejection is due to the cells of foreign person. So we decellularize after growing, forming this extracellular matrix. We remove the cell, and so the remaining this vascular graft can be shipped to the patient, and we can use it. So this is bioengineered vascular graft. Okay, so you can see this airplane too. It's a very important. So for example, this is tissue engineered porcine arteries. So this is origin from a pig. Okay, period 8 weeks. So let's move on a little bit further from scaffold-based tissue engineered vascular graft, or TEVG manufacturing. So this is still, I have to say, it's not perfect, but we are trying a better way. So let's look at the idea how. So from human, we are patient, we extract the cells and isolate the cell, and we expand in cell culture. Okay, and there are two ways of generating this vascular graft. One is we mix the cell with a polymer scaffold so that we have this mold that looks like a vessel, and then we shape in a mold and then a bioreactor to grow of these cells to fill these gaps. And another way is we just take out only the cells, and we already pre-made a polymer scaffold, like porous scaffold, so that the cells can be seeded into this porous polymer scaffold, and then you grow and the cells, and then make a tissue engineered vascular graft. Okay, so then comes the question of how good would this artificially made tissue engineered vascular graft. So people have already studied, and the conclusion, I would say, is it's always so far the case that you take your own vein vessel and then use it for graft has been always better than this artificial. But probably there are cases if the patient suffers from vascular systemic disease, and it might not be possible. So let's take a look at the data, because so in opposing to this, your own vessels is probably the best. And how you get it, you will see the patient leg you can have a small, simple procedure to take out the veins. So that's called saphenous vein. And then use this one to chop and then use it for bypass surgery. Okay, so let's compare this versus engineered one. And these data extremely demonstrates what would be the result. So the x-axis is years, y-axis is a patency, which means how much of this opening is remaining. And all these field circles are for SV, stands for saphenous vein, while all these empty ones is PT, FE, or this is the vascular graft. Okay, and you see all these field ones are higher, even 5 years, they are like 80, roughly 80% patent, while the empty ones, which is a vascular graft, you see they are decreasing over time, and even like decreasing in just 4 years, it's like useless. So it requires a more further procedure. So that's this data, even with the CABG, okay, coronary arterial vascular graft case. Even if you use your own vessels, what happens is about 10 years of use, the patency is known to drop to 50%. So only 50% is remained. So yeah, that's something still it requires more research and more better efficiency with this engineered blood vessel. So data for CABG, coronary arterial bypass grafting using PTFE conduit. So polytetrafluoroethylene conduit, which is or this open data. So that's another aspect we have to consider is this kind of biomaterials, which is in contact with the blood. And what the problem is, as I asked Yungu about blood clotting, and that's clotting is a big issue, and we have to know. So the process of blood clotting is in fact very important. It led to multiple Nobel Prize for this study. So what is coagulation? Coagulation is a result of cascading chemical reactions of plasma proteins, especially clotting factors. So that we call as coagulation. And what happens here is this cartoon demonstrates and trapped RBCs, red blood cells, and you can also see platelet is critical for this. And then there is a fibrin mesh which traps RBCs and form a blood clot. Okay, and this process we call as a coagulation. Let me see. Cascade. Okay, and the reason of this is formation of blood clot is a very precisely regulated series of interrelated and enzyme-mediated reactions. So it looks very complicated, but I want to explain this cascade into two different ways of process. One is called intrinsic pathway, the other is extrinsic pathway. So first, extrinsic pathway is causes from external, so such as tissue injury and vessel damage will cause blood clotting, because you don't want to lose your blood volume, which means losing proper pressure, and if it's loss of blood is too much, you can get in coma because of the shock, which the heart cannot produce enough pressure gradient. So to prevent that, we have extrinsic pathway to activate to form blood clot to protect the blood. And another intrinsic pathway is from more of the other side. So for example, all your blood are actually getting direct contact with the endothelial cells. So what if? So we have a evolutionary mechanism that if the blood are getting in contact with something it is not supposed to contact, that means there's something happens and we have to protect. So if it faces with charged surfaces, especially exposed extracellular matrix, when it comes to face extracellular matrix, it triggers, intrinsic pathways of blood clotting. And also biomaterial, which we will discuss later too. When the biomaterials are getting direct contact into the blood, usually the blood's plasma protein will just quickly coat, and we call this the adsorption. And that coated, protein-coated biomaterials will be also provoke pathway of blood clot. So that's why it's dangerous, and you need a like so-called blood thinner or anticoagulation therapy if you have to use biomaterial for this purpose. So here comes the rather complicated looking. I want to just focus on what's important here. So intrinsic pathway and extrinsic pathway, and it provoked by this surface, okay? And this one's triggered by vascular injury, which is here as TF is a tissue factor. And there's a number of this multiple enzymatic, okay, reaction. This small a means activated, okay, activated, and you can see there's calcium ion involved. So what's important here is when it goes down, so this is a cascade of reactions, and what it does is actually converting prothrombin, pro is the precursor, okay? Prothrombin into the thrombin. Okay, that thrombin is what it does is making a soluble fibrinogen into the fibrin polymer, which is cross-linked, and that's insoluble. And that fibrin polymer forms this fibrin mesh. Okay, that's triggered by a thrombin, and the thrombin itself go back to make this enzyme to be activated so that this process of cascade will keep running. And this time of feedback we call positive feedback. So it's like, running a snowball, okay? So this is a very precisely, invented methodology for, because this is very critical and very important. And likewise, extrinsic vascular injury also causes this prothrombin to thrombin. All right. And so for that, this is our natural mechanism to protect ourselves. So that's the good thing. But unfortunately, this very important for survival mechanism can be bad. Okay, so when does it happen? The end point of coagulation cascade is in fact formation of cross-linked mesh of the protein. Let me see. Let me show. Jisoo? Yeah. Yeah. Can you guess?
Fiber.
Oh yeah, close protein. Maybe here. Then May says you can find some answer in this picture. So cross-linked mesh.
Fibrin.
Yes, exactly. So that's protein fibrin, and that fibrin cross-linking is generating a solid material by trapping these RBCs and also platelets within a protein-rich network. And of course, why this is neat? This formation of this will close the vessel which has a leakage of damage and stops bleeding. So if you look at this cartoon and this nice electron microscope graph, which is painted by, properly for RBCs with the right, but you also see the whitish these networks, because this is an intrinsic mechanism. When there is a cut in the blood vessel, that's an emergency, right? So RBCs will leak out, and this platelet, in fact, the platelets, when it comes to direct contact with the outside of blood, such as extracellular matrix Okay, so that actually triggers, hey, there's an emergency. We have to block this leakage of blood because there's a breakage of blood vessel. So the platelets will become activated first, and then forming this cascade of coagulation to form a solid clot, which will block this leakage. Okay. So, but this life-saving process can become sometimes unwanted formation of clots, which is for example, embolus, which in first class I told you, thrombus is inside to blood clotting, but the traveling blood clot, we call it embolus or emboli if it's multiple. So traveling clot, what is the problem? They can block smaller vessels. Many times it's in the lung, okay? But sometimes when it goes into the brain, it becomes a bigger problem because it will impede or block blood flow to tissue. So embolism can lead to, if it lodges in the brain, that can lead to stroke. And or if it lodges into the lungs, it can cause a breathing problem. Of course, it's a lung. Okay. All right. So in the end, biomaterials that will direct the contact with the blood, there's both intrinsic and extrinsic pathways of coagulation. And what's very interesting here is we utilize positive feedback, which is like, like self-amplifying process due to the this is a little difficult, so I'll ask the material science crew. Kim Jong-hyun?
Yes.
Yes, can you guess what this is due to the? Yeah, this is a little difficult. If you look at the clotting cascade carefully, you'll find that positive feedback is due to the thrombin, and that leads to outcome of the formation of fibrin. So that's the key part of this clotting cascade. So I have to say, there are even biomaterial like specialized lasers as well. Why do we need? Because up to now, no biomaterial is totally inert. So that's the issue. Okay. So let's review intrinsic pathway. It's activated by presence of charged surfaces. So for example, blood direct contact with a collagen, which normally they doesn't, okay, in the sub 승형. So when the blood contact into collagen, they don't see collagen usually, but if there's a cut or damage in the blood vessel, there will be contact with endothelium. Okay, endothelium or with a biomaterial, and that requires a number of clotting factors like 7, 9, 10, 11, 12, and calcium ions are important here. And what about extrinsic pathway, which is activated by, so extrinsic is really causes extrinsic trauma to vascular walls and surrounding tissues. And then clot formation in response to this 승형 again, and tissue and vessel damage.
Injury.
Yes, exactly. Yeah, right. So that's an external cause. All right. So we have discussed with the biomaterial direct contact with the blood. Okay. And now we'll discuss about biomaterial, which is not direct contact into blood, such as like implant into the body. Okay. So that we call biological response to biomaterial, especially very famous term called foreign body response to implanted biomaterials. So when we have a implant, whether we need it or not, sometimes you see even pacemaker is a foreign body inside the body, or some filler for cosmetic purpose is a foreign body too. So, but the body is, recognize self versus non-self, which is our immune function. And the complex response to implanted biomaterial is due to the presence of our blood and interstitial fluid, because biomaterials are in contact with either blood, interstitial fluid, and of course, directly in contact with multiple kinds of cell types. Then what does the body do to protect ourselves? So first, protein from our blood and interstitial fluid will first cover the surface of this foreign material, okay, that we call adsorb, okay? It's not absorb, it's AD, adsorb. So you have to know the subtle differences here. And the cells may interact with this protein layer and not directly with the material surface. So the response is a little bit more consistent. And that we call typically foreign body response or foreign body reaction, or FBR, okay? This is a unique inflammatory response, and that will result in the formation of foreign body. And I think this is a little difficult for many, but we will make a giant cell to respond to this, okay? And I will show why we call it giant cell, foreign body giant cell, directly on the polymer surface. And so what we want to do is, if there is a foreign body in our body, let's assume like some cosmetic implant, let's say breast implant into our body. And then what we will do when it comes inside the body, it will be covered by our protein absorption, and then by itself will cause an inflammatory response, okay? And then our cells, especially immune cells, get in and then try to look at this and then try to, remove this. But when you cannot do it, then even it's inside the body, you will make this one to isolate from our body by encapsulating with a fibroblast and collagen to make it almost outside of the body. Or persistent inflammation can be a problem, and that can be a problem. That's why you have to reconsider whenever you think about like implant into your body. If it's cosmetic purpose and not other purpose, you have to maybe rethink and look at all the risks involved. So one as an example for this, I brought this a surgical suture, which will eventually cause a foreign body giant cell reaction. So the surgical suture and this a nice H&E or hemotoxin and eosin stain. You see in the central part, it is suture because it composes of multiple threads. And you see this nice cross-sectional view over here. But what you want to focus is surrounding this suture, the shapes of the cells and densities are different from the other part, which is muscular layer. Okay, so that we identify giant cells. What does that giant cell mean? The cells will form, multiple cells will actually fuse together. So it results in multiple nuclei. So multinucleate foreign body giant cells form from M fusion. Because what kind of cells will first respond to this foreign material? Like the cell-eating immune cells will come in to try to eat up. Okay, that's by the name macrophage, big eater cells will try, but it can't. So what it does is this macrophage will be fused together to make a multinucleate, a huge big cell. So that's a foreign body giant cell but still you cannot eat this is something different. So that's kind of the response of our body. All right, so here I brought some picture of a how things will happen for this process in different viewpoint. So for example, so first a monocyte. A monocyte is an immune cell which exists inside blood vessel, okay? And when there's a biomaterials get inside the body, which could be either soft or hard tissue, and that will trigger immune response by secreting molecules. Hey, there's something going on here. Then that chemical driven movement of immune cell, we call it as a chemotaxis. And of course, immune cells will be migrate into the site. And monocytes, when it comes out of the blood vessel, and it will become a macrophage. And they will go to this biomaterial and tissue interface. So they migrate and they adhere and they differentiate into a macrophage, and even it cannot do it. So then what they do is signal transduction and activate this macrophage into a foreign body giant cell. So that's a transition from blood circulating monocytes to biomaterial and tissue interface and adherent monocyte macrophage to form foreign body giant cells. Okay, so let's look at this process into more of a temporal aspect. So this, when the foreign body is implanted in the body, we can consider this process as a different time scale. So the time scale can be within an hour, around the daytime, and within about a time scale of week and time scale of month. And you guys will remember, like, for example, I have an experience of, let's say, this pencil tip. By mistake, this pencil tip was getting into my finger and I can't take it out. So that, like, carbon is inside my finger. It's kind of annoying, but now, like, after years, it's gone. So how does this happen and what might have happened? It was irritating at the beginning, and in the end, it somehow I didn't do anything. It actually comes out of my body. So in that biomaterial gets into my body, then within an hour, what happened is, inside our interstitial or some blood, the protein will be coat this biomaterial, and that we call protein, let's say, Shukla. Yeah, I can't hear you.
Yes, Professor.
Shukla? Can you? Okay, I think I see your saying mouth. So that's protein adsorption, and that's in the time scale of like seconds to even up to an hour. Okay, so very quick. And then within a day, what happens to this site? Okay, within a day to this site, there's a inflammatory cells getting in, which is a neutrophil. The first one is neutrophil because there's an acute inflammatory response, and then try to attack this part. And then macrophage comes. So this happens only in about a day order, 1 to 2 days. So that acute phase, and still it doesn't work. So for about a week order, like they struggle to try to kill and engulf this, but without success. That's what happens. That frustrated macrophages will form so-called giant cell formation, and then they will try to kill. So the cells will secrete, these immune cells will secrete so-called a cytokine. And you hear a lot about cytokine from this COVID-19. And cytokine is a substance for example, interferon and growth factor, and they are secreted by immune system, have an effect on other cells to recruit. Okay, for example, fibroblasts can be recruited, so it takes more time, about a month or several weeks order. The fibroblast comes in. Hey, now we can't deal with this guy anymore. Let's just encapsulate this with collagen, and let's consider this out of our body. Okay, so biomaterial after several weeks or month, then dense avascular, there's no blood vessel here, collagen capsule will be formed. Okay, so that's a natural process of implanted biomaterials, which is originally to protect our body. But what happens? And for example, like there are Parkinson's disease patients who require implant of deep brain stimulator. And that electrode, once get into our body, they have to send out current for therapeutic purpose. But with this response, over time, this collagen capsule will change the electrical conductivity and change the effectiveness of implanted bio, in this case, electrode. So that has become a problem. So that's why to understand this process, and if necessary, how to relieve some of these changes for persistent effectiveness of some kind of biomaterials. So those are something I think we have to think of. All right. So protein absorption, I brought another picture to think this process a little more, other specific aspects of this implantation, and we see protein absorption and recruitment of immune cells such as neutrophil and macrophages from the blood is coming. You can see neutrophil and monocyte comes in and it turns into macrophages. And then macrophage now fusion to form a foreign body giant cell, which you can see FBGCs. And later stage, tissue specific. So we call this as a fibroblast comes in, and also endothelial cells, and try to encapsulate of the implant by a fibrous capsule. So I hope this is clear to you. And so there are like how to study this, how we have to understand about this, by basically we did an experiment. So here comes the experimental results. So the left part A is SEM, or scanning EM electron microscope, to show what happens. So we expose heart valve to calf blood for just a few minutes. Let's try to see only a few minutes what happens. And then we look at the surface of this biomaterial, and we see here the surface is undulated. So it's not like original flat, which indicates there's a protein absorption happen. Okay. And then also experimental tissue. But here, I think I want to discuss a little more. So this small a and small c. Okay, and this is a red blood cell. So somehow RBCs are like attached to this, and you can find out, and U and A. So this U is unaffected platelets, and A, the difference of this is platelet has some arms coming out. Okay, that actually indicates and activates the state of platelet, like that's in the blood clotting. So, and so you can see this clumps of this clot. So I brought this picture of, platelets are not the same when they are unaffected versus activated platelet will have this very interesting, maybe angular shape, okay? That we also experimented tissue reaction to relatively inert biocompatible material, and then we take out, okay, and make a cut to see what happens to the surface. So this M stands for this material, and this is a muscle layer. And you see in between, there's a thin fibrous capsule has been formed. So you can use a special stain for collagen and realize this is a collagen. And also, some of this, after surgically implanted this suture, many times it's okay, but sometimes or in transient there could be an inflammation problem can happen that we call granulomatous inflammatory response happens of here. The reason is this GC or giant cell. Okay, and here I just want to tell you about granuloma. Explain this granule as a like grains, like rice or this. It comes from grain. So loma. Oma means a tumor, okay? So it's all mass. So mass of granulation tissue, and this is a produced in response to infection, inflammation, or a foreign substance. For example, TB or tuberculosis also it's very famous for making special type of this granuloma, okay? So this is an example for that. So at the last part, I want to discuss about open heart surgery and medical device. So this picture shows a picture of the surgical place of open heart surgery or so-called cabbage surgery. Here, coronary artery bypass graft surgery. And you see patient heart is open, so this is chest is open. And you see the patient left leg, you see this cut. This is to take out the softness vein from the patient. And think about this arterial bypass. The heart is beating like crazy, okay? And it's very hard to do surgery because you have to do this fine vascular surgery. So what you have to do is suppress the heart beating, okay? Because you need to suture and anastomose or connect the blood vessel into another. So because of that, then what about the heart's original function? You can't. You have to replace during the time. So there comes this big machine which will perform the heart and also, of course, the lungs function during the time that we call heart-lung machine. Okay, and this surgery has a lot of problem too. So, and I want to discuss about this open heart surgery, and this is the same picture, but I want to explain about this procedure. So the patient chest is open, fully exposed the heart for operation, especially, for example, heart transplantation and cabbage surgery or replacing heart valve, you do need an open heart surgery. And let's look at the data of how many times we do this so-called CPB or coronary cardiopulmonary bypass. So the number of procedure will actually decrease over time, and the black one, which is OPCAP, CAB, which I will discuss next slide, because there are a lot of problems involved by stopping the heart and using this external device, and so that's we call CPB or cardiopulmonary bypass. Or in simple words, heart-lung machine, because during the surgery, you have to replace the heart's function. So you have to take out inferior, superior vena cava to take out the deoxygenated blood. You have to reoxygenate, it's a lungs function, but you have to push it into the aorta, so you need a pump. So this heart-lung machine, okay? So CPB is a technique forms of extracorporeal circulation that temporarily takes over the function of the heart and lung during the surgery. And this cardiopulmonary bypass is commonly used in cabbage or coronary bypass heart surgery because it's very difficult beating heart surgery. Okay, so this is a diagram that you take out from veins and venous reservoir, and you actually oxygenate it, and then you using pump, you give it back to the aorta. So this a common surgery called cabbage surgery, and the problem is, for example, I had a classmate whose daddy had like, when it comes to open, and the daddy needs like has a 6 bypass, and I didn't understand what 6 bypass. And look at that, because some patient may have only one part of narrowing down that requires a single. So you see this narrowing down part, you have bypass, and then you connect this to the aorta. And but sometimes there's multiple, 2, triple, quadruple. You see how this cabbage surgery is done. So very complicated surgical procedure, of course, to restore normal blood flow to an obstructed coronary artery who suffers from arteriosclerosis or atherosclerosis. So arteriolar rigidity and atherosclerosis. And cabbage is performed with usually for the heart has to stop. So it requires a cardiopulmonary bypass or CPB, or we call on pump. And what we want to know is the risk of infarctus. Okay, so it's not simple, but so risk to patient and complexity of the operation. And during the surgery, debris can be released. This fatty material can form a blockage, and from the lining of arterial walls may break during this cabbage procedure, resulting in a traveling clot, so-called emboli, traveling clot. When it gets to the brain, unfortunately, the patient suffers from a stroke, or that can lead to neurological damage. So how devastating it is. So not all patients, but there's a risk of this. So there comes an idea from Japan. Japanese surgeon made another idea. Hey, why not let's keep the heart beating, but just it's so hard. You see the heart is beating like crazily moving, and the part your surgery is no. So the idea is, why don't we try to suppress that part of surgical site while the heart is beating? Okay, so that's the idea. While this is more difficult, but you may have much more benefit. So let's not use pump. So it's called off-pump coronary artery bypass, or OPCAB. So you remember that the statistics, it is actually increased, and that's quite a new innovation. Off-pump coronary artery bypass or beating heart surgery is when you do cabbage or surgery. Let's not use this heart-lung machine. Okay, because this involves a kind of a higher risk of other problems. So even doctors say, I think a pump, I forgot the term, because pump head syndrome or something, because after this surgery, somehow many stroke can happen. The patient it saves life, but the patient has a problem. So what happens is how we do, is I will show you here. The idea is a very engineering approach. You just need a stabilization device which contains a suction pump, so that you suck the heart and then grab it firmly on the side of the surgery. So these suction cups will have this air is sucking to grab it, so the heart of that part is still stationary, so that you can stabilize. Of course, that it takes time later. We found that it reduces the incidence of stroke, but the problem is to get used to for the surgeon to do this surgery. It's technically more challenging, right? There's a pros and cons, but that happened 1992. This original inventor of this surgeon of Japan, he actually performed a Japanese Japanese king surgery using this. So that actually demonstrates the emergence of this technique, the benefit of this. And in fact, in 2010, if you look at to the Nature method, I think I forgot exactly, when we have, there's a paper for mouse endoscopic heart imaging, because it's the same problem. They actually use a small pump to grab the mouse heart and then do a microscopic imaging. I think that idea comes from this original human trial, and that's innovation in terms of endoscopy of heart. So that leads to a later paper. I think so. That's kind of something, if you know how to solve problem, this can lead to many interesting ones. So the other thing I want to discuss is percutaneous coronary intervention, or angioplasty. What it means is this stenosis, or a blood vessel. You give a balloon and then inflate the balloon so that physically making a bigger open. So that's angioplasty. So here is the, I actually have to show. So let me show, change into this. I want to stop sharing and then share it again.
Coronary artery disease is narrowing of the coronary arteries secondary to several risk factors, some of which are cigarette smoking, hypertension, hyperlipid.
Can you see?
Percutaneous coronary intervention, or PCI, is a procedure used to treat and evaluate completely occluded coronary vessels. Atherosclerosis results from endothelial injury, inflammation, and accumulation of lipoprotein, leading to intimal deposition of particles and narrowing of the coronary artery. The stenotic vessel makes it difficult for red blood cells to pass through. Therefore, the risk of ischemia and infarction is increased. During a percutaneous coronary intervention, an incision is made to isolate the femoral artery. A catheter is inserted into the artery and guided up the aorta to the heart. Live angiography is used to guide the catheter to the obstructed coronary artery. Radiopaque dye is injected into the artery.
See this.
Imaging determines the location of the stenosis and the diameter of the vessel. Once the vessel is isolated and the obstruction located, a guide wire is threaded through the catheter to the location. The catheter is removed, leaving the guide wire. A balloon catheter is pushed over the guide wire and centered over the blockage. The balloon is inflated to open the narrowed vessel. The balloon is inflated and deflated multiple times to gradually widen the occluded vessel. To ensure that the artery remains unobstructed, a second balloon catheter with a stent is threaded to the location. The balloon is inflated, expanding the stent. For some patients, drug-eluting stents are used to decrease the chances of in-stent stenosis. Drug-eluting stents are coated with a material that will retard new intimal hyperplasia. Blood flow through the coronary artery is restored.
Okay, stop share. Okay. So I hope this one is clear to you. Let me go back to this
Coronary syndrome, which is a syndrome characterized by a reduction or occlusion of blood supply to the heart. And so we begin by revising the anatomy of the heart just quickly. So the heart consists of 4 chambers.
There's an accident.
The left ventricle here will pump blood to the...
Okay. Okay, so that we saw that this coronary intervention through the skin, so we call it percutaneous coronary intervention, which, the revolution here is we now do not do any open heart surgery, which involves a lot of side effects. So we don't need a surgery, but procedure to treat narrowing, we call stenosis. Okay, stenosis of the coronary artery of the heart from this coronary artery disease. And this is a revolution in this cardiology. No need of open heart surgery. I mean, insert stent and naturally dissolving stent. And so this we call PCI and versus CABG. So CABG, when we have to open the heart, maybe extensive blockage or back, so which do not allow stent to resolve, or background of diabetes. Diabetic patients usually have a lot of vascular issue. So maybe through the vessels may have a higher risk of problem. So only those cases, but now PCI, it becomes more of a routine. So PCI or angioplasty, we already show that movie. So artery and plaque, and we have implanted stent, and then inflated the balloon, and then leaving the stent out. And we also discussed already about drug-eluting stent for angioplasty. And here comes the electron micrograph and showing drug-eluting stent. So, and the recent stent is actually metals can be even replaced with degradable polymers, and that braid, and we have coated elastomeric coating, and then providing elasticity to this stent. And also you add this drug-eluting layer. Okay, braid means this, like you can see from the hair. So this is the end of biomaterial. And when we develop and design artificial organ, this is very important, and perfect biocompatibility is not yet known. Okay, and what we want to know is when it comes to the blood directly, coagulation cascade and anticoagulation is important. When it comes to the body, except the blood, foreign body response is something we have to understand. And especially what we know of biomaterial, a very important one is this heart and stent. All right, so this is the end, and I want to finish by writing your questions to the to this base camp, and I think there are several remains students who haven't done Q&A. So why don't we use chatting to volunteer? All right, thank you for your attention.